Hello, and welcome to Pain Options Education. This is the place, Tim, for topical issues in musculoskeletal pain, or for discussions thereof. It's where we take a common sense approach to current research and evidence, and we help fine tune your clinical practice. And mine has certainly been fine tuned over this last series that we've done.
Good, and your intros have been fine tuned.
They'll take some work, but that's okay.
Yeah.
I will be Darren.
I know.
Thanks. I was going to say my name was Nerid, which is my name backwards.
I'm Mitt.
So I'm welcome. I'm Nerid.
And I'm Mitt.
Nerid Salabes is my name backwards.
I'm done. I'm out.
All right, pain sensitivity. We're here at the last episode. If you watched them in order. If you didn't watch them in order, it won't be the last one. Do we recommend you watch them in order?
Yes.
Okay. So today we're just going to take on a few caveats around that are pretty much, I think, essential to understanding pain sensitivity. A lot of this comes from the research, but it has some implications around interpreting the clinical findings, and certainly in terms of translation to the research evidence to clinical practice. You need to understand these things, and really, so once you understand this, you can see why a pragmatic approach is so important that we spoke about before, because there is not clear evidence around this in a lot of ways.
No, we're talking clinical concepts here.
Yeah.
Obviously, with evidence that we have been able to interpret and somewhat be involved in a little bit of that to date, but it's definitely a moving, sort of changing area that we're trying to introduce some clinical relevance to.
Yeah. And it reminds me of the evidence triangle with the meta-analysis at the top, but you cannot forget the one-on-one clinical interaction is part of that evidence framework, and it often gets forgotten.
Yeah.
And it's a very important part. And I think that's, we're taking that and melding it with those other forms of evidence, hopefully, in a common sense manner. One day I'll do that right. So for the last time, pain sensitivity in the clinical context can be considered as a term used to encompass the phenomena that some people experience, and perception of pain is enhanced beyond that of others. Do we need to change that, Tim?
I'm still sticking with it, Darren. So
Me
the
too.
key bit there is some people's experience and perception of pain is enhanced beyond that of others.
Yes.
So you can have two people with the same problem with very different responses around their pain experience.
Yeah.
But on top of that, as we've talked about, there's very different reasons behind why they may be pain sensitive between different people. So that's what makes it interesting from my perspective.
And I think every musculoskeletal therapist can appreciate that people with similar presentations can be completely different. So this gives us a good understanding and reason why.
Yeah.
I was trying to remember why I put the umbrella in twice, maybe because I was just so happy that I got the umbrella in last time. I would flip it in there again. But it is just a reminder that these are the different, we work across lots of areas and domains. We have lots of interventions that affect multiple domains and different domains for different people at different times. And let's not be too harsh on the evidence of it from the caveats point of view. From efficacy, as I said before, the clinical encounter is a very important part of evidence, and we need to not throw these things out. And we've seen, schools in Australia, throw things out because there supposedly wasn't enough evidence for it, and it hasn't helped really.
No, we've got to be mindful of not to continue doing things that are shown to have no effect.
Yeah.
But some of the things we do have effects for different reasons than what we perhaps originally thought, and that's okay. But yeah, keeping that broad perspective on what we're doing and reviewing that over time is important.
Yeah. Okay, so QST or QQST, as I'm rephrasing it, was not primarily designed for all musculoskeletal pain. It was designed for neuropathic pain, in fact. The methodology has been taken and applied to other pain conditions. So there's a growing research in that area as well. But in essence, you can't just take the research from neuropathic pain and expect that it will fit all musculoskeletal presentations.
Agreed.
All right, well, we'll move on from that. Sensory testing is unable to delineate specific pain pathways. We don't know from putting a sharp stimulus on someone's foot to the perception of pain in the brain and verbalization of that perception. And maybe they've had a hyperalgesic response to that where the pain response is exaggerated. We don't know from where the stimulus is applied to where it's verbalized as pain, where that wind up of that message or the facilitation of that message, enhancement of that message has occurred.
Yeah. And the sensory testing like we're talking about is the sharp, the light touch, pressure, deep pressure, cold or temperature changes, and it's almost, I'm trying to think of the right word here, it's almost empowering to accept that concept. So we're not trying to use these tests to tell us exactly what's wrong. It just tells us, and we say this often when we talk in teaching, to go, well, that tells us that test was positive, or that tells you that you're sensitive to that stimulus. That's all it tells us, and nothing else.
Yep.
But that alone can be helpful as one part of the overall picture. When you combine that with other components, suddenly you've got a story that makes sense for that person.
Exactly. And that may well be the ultimate downfall of the producers of medications in the end. I mean, they're trying to use this testing battery to isolate specific pain pathways where they can do a targeted medication, but it's bound to fail given the complexity of the whole chain of communication from foot to brain.
I would think so.
We won't be getting any drug companies sponsoring us, Tim.
Damn it. Oh well.
All right. We'll try and make up for that some other way. Wide range of responses to sensitivity tests in the general population. I think this is very important because you could take a person that doesn't have pain and they can be pretty sensitive on this testing. Yeah. So it's so important not to just take this testing in isolation, and hopefully we've portrayed that it's part of the broader view of the patient.
Yeah, and that sensitivity term, as we've talked, can be replaced with efficiency of the system. So that makes sense. Same with our cardiovascular or muscular system. There's efficiencies in people's systems that differ, which make us different people more skilled or better at certain things. But some people's pain system is more efficient, so they might be more sensitive. It's not their pain system really, is it? Their somatosensory responses are more efficient. So that doesn't necessarily mean they've got a pain problem, though.
No, not at all. They're just more efficient, as you say. Anything else about that? I don't think so. I think that's pretty good. Flying through these. Sensory testing is not clearly related to pain and disability. I mean, we started with this at the start. We talked about it in terms of subgrouping way back in episode 2, I think, the paper of Martin Raby. I can also cite a systematic review. It's a few years, a meta-analysis from a few years ago that clearly showed that there wasn't a relationship between these things, but that's okay.
So let's take that to the individual patient level, if you like.
Yeah.
So just because someone has got increased sensitivity, that may not tell you how much pain they'll report or how disabled they are by that pain.
No, but it may tell you their prognosis, or it may tell you how they'll respond to certain treatments.
Yeah.
There are certainly, contrary indications in the research where someone with back pain but actually has more widespread pain is more sensitive than someone who has localized back pain. But then you're not talking about localized back pain and like conditions, are you? You're talking about a widespread sensitivity disorder. So, there's labeling issues in that as well. But yeah, I think it's highly valuable, but that basic logic of sensory testing is going to be worse, your pain's going to be worse, doesn't work. But that's not a reason to be disturbed. That's just the way it is.
Yep.
I've thrown this in there because we talk about the biopsychosocial model. If we just take pain sensitivity of a construct itself, then there are multiple things that can influence pain sensitivity, in the general population, not just those with pain. Yes, I have put this interesting picture there because one of the big ones that comes up in research all the time is sex, and you need to adjust for sex when you're doing any research around pain sensitivity.
Mm-hmm.
And if you're reading a paper and they haven't adjusted for sex, throw it in the bin. No, not really. It might still be useful, but sex is a big thing in research where sensitivity is different between males and females. But I would say in clinical practice that never even comes into my mind. Like, I get blokes that are wound up and females that are wound up. It's not discriminatory to my mind.
So is that beer or wine that's more helpful in terms of treating this, or no?
Well, when you're a clinician, if you're getting depressed because you can't deal with these complex patients, I would say maybe have a couple of beers and then a glass of wine after.
As a short-term strategy.
Short-term strategy.
Very good.
Good night's sleep. You might think about it during the night and wake up with a revolution.
Good.
So age is another one. There's just so many factors. Obesity, pain features. If you have pain comorbidities, they can be an issue. There's related to pain sensitivity, psych stuff we've talked about, exercise levels, sleep. So many factors related to pain sensitivity that speaking about it in isolation, as we have tried to, seems a bit foreign or.
Yeah, it's not how we function, and I think having those listed there is really important because that's exactly what we do. We go, right, this person's got increased pain sensitivity, so what?
Yes.
And then we might go down that list there on the left, and based on their story of what they've told us and what we've looked at in conjunction with them to work out what's going on, then you might have a clearer picture of some of those factors that are individually relevant for people.
Pain sensitivity might be helpful. We've spoken about this in terms of maybe acute pain or in more persistent pain presentations where pathology is an issue.
Yep.
We probably don't need to go over that in great detail other than to recognise it can be helpful for some people.
Agreed.
That brings us to our paper of the day. And I know your Arabic is very good, so I won't even bother asking you to.
I won't show up.
I pulled this paper. When this paper comes, here we go. Oops. Can QST move us closer to mechanism-based pain management? And it's a very good question, and it's kind of a summary around that. We've touched on this point already, but I will give you a quote. QST assesses the integrity of the entire neural axis from receptor to brain. Thus, QST can provide information regarding large myelinated A betas, thinly myelinated A deltas, small unmyelinated C fibers, and their corresponding central pathways, although it cannot provide information on the exact source of somatosensory dysfunction.
So that sums it up in the research setting and getting some different information versus a patient in front of you in the clinic, and trying not to ascribe too much meaning to an individual clinical sensory test.
Yeah, they're saying the same thing, that we can apply this stimulus, get a result, but we don't. And we know it's these different pathways, but we don't know which one's being affected. All right, good. So I believe that would bring us to the end of our series on pain sensitivity. Any final questions, thoughts?
There's questions daily about this, Darren, because it is such an interesting and important topic and it's evolving. So if people have questions, that might help us with our thinking and understanding as well.
Indeed it will, and you can send those questions to education@painoptions.com.au. Well, it's been a pleasure, Tim, speaking to you over the last 7 episodes, and kind of sorting through some of this controversy and difficulties with pain sensitivity. I think it is something that you need to sit with, over time and think about it as you go along. And it's not something you can just read about and magically understand, particularly in the implementation.
Yeah, and I think working with different people or looking at patients or discussing this and getting different perspectives, it definitely evolves your understanding over time, as long as you have the right information available, and hopefully this is a helpful part of that in the current knowledge and understanding at least.
And it is, I don't know, what is it? It's May 2020. So if you're watching this in a couple of years' time, we may have changed our minds.
It's a good chance.
Good. But we won't be pain scientists, will we?
No.
We'll be clinical pain scientists. Thanks for listening.
Cheers.
Bye.